Thank you, Dr. Coleman, and Sinrit Parmar for the invitation. It's actually it's very pleasant to be in a meeting where we can talk to people. You know, our meetings are becoming so large and so lacking of interpersonal interactions, and this has been a very good, on the opposite side. You know, we're having plenty of time to see people and talk, and this is great. So now, let's talk a little bit about curing some patients. Huh? Just kidding. I was charged with talking about CML, which will be most of my talk, and I'll try to touch a little bit on myelofibrosis at the end. So we all know that CML is curable by transplant, right? I mean, this is a final result of both chemoradiation, but above all, a very strong graft-mediated graft versus leukemia effect. And the enthusiasm for that is obviously always hampered, as we've been discussing here yesterday and any other meetings regarding transplant, is always graft versus host disease, which is it includes a strong impact in quality of life and so on. So that's the balancing act, and you saw obviously what has happened to transplanting CML because of that risk of graft versus leukemia. As a background, I'm going to remind you that this still holds true. So this is an old EBMT, the European Group of Transplant. There is a risk score. Has a lot of almost self-fulfilling things, but the older you are, if the disease is more advanced, going away from siblings, and there is a sex mismatch transplant. So these are factors that impact survival of transplant. So the factor that may have changed a lot is right here, time to transplant. But be that what it may, this thing has stand the force of time. You can still counsel patients based on this, right? I mean, the ultimate nightmare is an elderly patient with a mismatched donor in, say, late accelerated phase. So invariably, the expectation of treatment-related mortality and survival will be low and very high here. So this is very intuitive, and I remind you of that. The other benchmark that I want to remind you is Dr. Jabour's presentation. So I'm not going to extend on this. So the revolution imposed by the tyrosine kinase inhibitors. So let me just skip this. We don't need that. This is just the Dr. Drucker's and New England Journal of Medicine paper. So what happened since imatinib? Since imatinib came, this has happened to transplant. So you can see here, this is years, and you see this chronic phase 1. As the years pass, the proportion of patients transplanted in chronic phase 1 has gone down. We all know that. While the amount or the proportion of patients transplanted in more advanced phase of disease has gone up. So we all know that. And even the patients that we at MD Anderson transplant in first chronic phase usually failed an average of 3 TKIs and very often 4, which has implications, remember, for what you do after, because we discuss a lot of times, or what can we do TKIs after transplant? Well, that is also becoming very complicated because most of these patients are resistant by definition to all of them. I'll come back to that later a little bit. Now, do the TKIs influence transplant per se? And I think there is reasonable evidence to say no, they don't. We and others have shown that there's very little in terms of toxicity, at least early toxicity, when you use TKIs before transplant, and that's probably true for all of them. And in terms of transplant outcomes per se, it doesn't seem to. However, keep in mind that if the patient jumps, obviously, from chronic phase to accelerated phase to blast crisis, that's absolutely going to impact the outcome of transplant, but it's not a TKI per se. I think there are 2 questions that I want to pose here. Not necessarily I have the answers, but one of them is right here. Does the delay to transplant decrease the likelihood of cure? So it doesn't seem to, as long as the patient remains in chronic phase. Right? That's the key issue here. And it doesn't matter time if the patient remains in cytogenetic CR. Probably doesn't. On the other hand, you probably are not going to take this patient if he's in cytogenetic complete remission. So these questions are kind of conflicting. What about the imatinib-resistant patient? So you saw Dr. Jabour's presentation. I think the answer is a no. However, there are ways to tease out these populations. And I picked one This is actually, I don't even know, Elise, has it been published? I know this is as an abstract in JCO, right? So the message here is that as long as the patient remains in complete cytogenetic remission, fluctuations of PCR levels only for BCR-ABL have to be seen very carefully because they may not imply worse prognosis. Okay, this is the major message. What you see here is that only a subgroup of patients, these are all patients in complete cytogenetic remission in chronic phase, only patients who had never achieved a major molecular remission or those who lost that remission had significant progression, okay? As opposed to all the others who had less than that. So it seems reasonable that the patients that are very, say, warning, having very red lights blinking there, are those who lose a molecular or major remission and have at least one log going up in their PCR, or those who never achieved a major molecular remission and also are having one log increase. So those are warning signs that you would consider transplantation sooner than later. All right, these are things. Now, let's see. So here, the other sign that I want to remind you is that something that Dr. Jabbour already mentioned, with the new TKIs, time to response is shorter, right? So conversely, the small minority who do not achieve benchmarks, warning sign. So you can paradoxically have, say, look at this. These are patients with nilotinib or dasatinib, although these are after imatinib failure. These are not up front, but illustrates my point here. Those who achieved at least a minor cytogenetic remission at between 3 and 6 months are likely, very likely, to achieve a major cytogenetic remission later on, as opposed to the others. If they do not, they are very unlikely to achieve that. So same, not necessarily the same numbers, but the same idea holds true if they're getting these drugs up front. So this is another exercise to help you. Keeping in mind that this is going to be, as you saw from Jabbour's presentation, a very small minority of patients, but they are real. So message is, earlier time points appear to allow prediction of maximum response to therapy when you're using the other tyrosine kinase inhibitors. Now, what about the mutations? So those patients that are failing somehow therapy are likely to be tested for mutation, and here's the big enemy. Although this may also change as ponatinib comes online. You have to remember that ponatinib may change the game here. But anyways, be that what it may, do these mutations affect transplant? And do these mutations affect the graft versus leukemia effect? And we think they don't. This is a very preliminary analysis that we did a few years ago. And essentially had a variety of mutations that didn't seem to affect the efficacy of transplant. The more recent, also Nicolini and I believe Jorge Cortez and a large group from the tyrosine kinase inhibitor trials looked at outcomes of patients who had the T315I mutation, and essentially also showed that disease stage determined survival, not the presence of the mutation. Okay. Now, more recently, what we did was a different exercise. We said, well, these are patients who have the mutation. So what happens with the other resistant patients who are sequenced but did not have mutations? So essentially, we compared a bunch of resistant patients that went to allogeneic transplant. A subgroup had defined mutations. The other group had no mutations, but they were sequenced. So the trigger of resistance was there, but we didn't find any mutation. So what you see is here that on a superficial look, the mutation folks in a darker line did, where are they? Here. The mutation folks who are here in this line did worse than the ones without a mutation. However, they were heavily tilted towards having accelerated phase and second chronic phase, while this other group here had more patients in first chronic phase. So ultimately, as you can see here, the survival was determined by being in chronic phase or not. And this is overall survival, and in darker are the ones that were transplanted in chronic phase. So again, disease stage, not the presence of the mutations. So that said, it's easy to say, well, if you're in accelerated phase, that's a transplant indication, right? In chronic phase, obviously, it's not anymore. That's the whole discussion we're having here. Now, what about blast phase? This would be a good question. Does anybody here transplant patients in active blast crisis? So we avoid that because the results are so poor. However, there is the fact that you can downstage these patients and then take them in second chronic phase, ideally, which brings them to a very solid survival similar to accelerated phase, 40, 50%. So every effort should be made to downstage these patients before they go to transplant, not in blast crisis. What about the preparative regimen? So let's talk a little bit about this because I want to show you some results. So there are two ways to look at this. One is the classic, blast everybody. That's the well-defined and classically defined approach, which is a myeloablative approach for patients with CML. Other approach, which is being proposed by Dr. Champlin here, is that, well, hold on a second. We're dealing with a disease here where people have way more to lose today if you give them lots of side effects and if you give them a lot of toxicity. So these are patients who have several other options. So maybe we can compromise and accept that reducing the intensity up front would be safer, and accept also that you would have to do post-transplant interventions to kind of gradually bring these people to a molecular remission without resorting totally upfront to a high-dose regimen. So this was at the time an idea like that, to use imatinib sequentially and possibly donor lymphocyte infusions after the transplant. And the transplant is done with a very light regimen. So what happened here was that, let me summarize this. Very early toxicity was very low. There was some GVHD later on, which you can see here, the 20%. And ultimately, those patients with early disease, survival is now, years later, at excess of 90%, with probably 30% of those with chronic GVHD. The catch was, there was a significant fraction of patients with more advanced disease who did not achieve molecular remission. So after this, we proposed to use azacitidine. I don't have time here to review the preclinical and clinical data that would suggest that azacitidine may help in lower doses after transplant by increasing GVL, or at least that's what we presume. And this here, you can't quite see the thick marks here, but these are the few patients that we treated in this protocol that were in chronic phase. I believe there are 12. And you can see here, most of them are way after a year here. So essentially for this small cohort, these are the patients we get that failed an average of 3 TKIs, but were in chronic phase still. Survival is 100%, which is pretty gratifying, doing this low-dose, stepwise approach. While you can see that for those that were more advanced disease was not so good. Anyway, so a lot of controversies remain, and we're not going to have time here. Stem cell source, some of these you heard yesterday, discussions. T-cell depletion, right, if this would help. The intensity of the conditioning regimen, as I mentioned. Haploidentical cord blood transplant, so we don't have time for that here, but these are issues that are likely to continue to be around. One thing that I want to remind you is that CML remains a very important model for us to think of immunologic approach to kill malignancy, right? I mean, you have to remember that there are several ways of looking at immune graft versus leukemia, or ways to kill CML by immunologic approaches. So I'm going to mention here one of them, which is Jeff Moldrum's looking at an overexpressed, which is a normal component of myeloid cells, at PR3 or proteinase 3 or elastase. You can derive a peptide that can be very immunogenic. And the other one that's also in clinical trials is Wilms tumor 1, WT1. And this is the work of Jeff Moldrum and Kazerbash, so you can find these things around. I just want to illustrate the point that your immune system can help eradicate leukemia. And remember that this may come back as we look into that cohort that Dr. Jabbour mentioned, those with minimal residual disease that are finishing their therapy with imatinib and have very tiny levels of BCR-ABL. This may be an approach to vaccinate them to eliminate their residual disease without allogeneic transplant. I would highlight to you a paper by Bornhauser, we're just publishing Blood, where he tries just that in the context of allogeneic transplant, using WT1 vaccination as well. And ultimately, obviously, you want to separate GVL from GVHD if you are in the transplant setting. But this is not necessarily the only setting. I want to, again, remind you of the minimal residual disease. Those patients, half of them stop imatinib and may be cured. The other half could potentially benefit from this. So where do we transplant? When do we transplant these patients? We're not going to go through this too much. I just want to remind you there are NCCN guidelines for that. The whole philosophic approach you heard from Dr. Jabbour here. I think there is also a nice paper from Dr. Goldman in 2007 that sort of breaks this in these little diagrams. You can refer to that. To me, the one question that sometimes we hear a lot is there any role for BMT up front? And this is obviously sometimes an economics game, which obviously applies to different countries differently. Right? Are there places where people do not have access to TKIs where transplant should be used earlier than all these things that we're discussing here? Probably. And we don't have time to discuss that. Leukemia net definitions of failure. I also refer you to this reference, which we're not going to talk about here, but I can give you the slides later. This is another important reference for you to know the definition of these failures. And I think it's reasonable to say that for those that you identify this mutation and you don't have access to ponatinib, transplant is a very reasonable approach, even in chronic phase. And for the others, you're probably going to try 1, 2, 3 TKIs. Let me see. And I think that the decision here is where you have to be very careful, because if they are in complete cytogenetic remission, and they are in chronic phase, even if the molecular levels are fluctuating, I would be very cautious at this point recommending transplant. And that's where that initial slide that I showed, showing risk-benefit for patients in that EBMT score, may help you think about that. So anyway, so I think ultimately for CML, the objective is the same, right? We want patients in complete cytogenetic remission. Some will get TKI only, some will go to allogeneic transplant. This is kind of a very vague conclusion. And that brings me to a little bit of myelofibrosis. I want to show you a few results of transplant for myelofibrosis. So here, I would be curious to see Serge Verstovsek comments later who he refers to transplant, because it's obviously a totally unclear field here, and we acknowledge that a very small minority of patients with these diseases will ever make to allogeneic transplant. So let me skip this because we talk about this. Prognosis, we don't care now. Let me show you the work of Dr. Uday Popat in our group. So what Uday has been doing is, together with Dr. Verstovsek here, transplanting myelofibrosis patients, either those who were primarily myelofibrosis or patients who had fibrosis secondarily as an end-stage result of other MPDs. So he has transplanted here patients with a median age of 58. You can see here the diagnosis down here. Oops, I think it's not. Anyways, the diagnoses are all here. Most of them are primarily myelofibrosis. And most of these patients, half of them would be characterized as a high-risk group. Some had a splenectomy. And you can see the karyotype here. Most were deployed. Most transplants are from mismatched or unrelated donors for these patients, and most used peripheral blood. And the interesting thing here is that what this curve shows is event-free survival for 26 patients as a function of a dose of busulfan. So this is a reduced intensity regimen. However, for, here in yellow, what we did was to titrate busulfan as a function of a systemic exposure, targeting an area under the curve of 4,000 micromoles per minute. So this was kind of a level like this. The green curve is where we simply reduce the dose to 2 days of busulfan. And interestingly enough, there seems to be a dose response, even within this reduced intensity approach here. This is showing to you that fibrosis may go away with transplant. This is one example here. And we also have spleen pictures. And there we go. So the spleen, so there is a graft versus spleen and graft versus fibrosis effect, I guess. Anyway, so this is just to illustrate that a small minority of patients with these diseases may benefit, right? I mean, it's a tough call. I'm not here to tell you who those are. They're likely to be the younger ones, good donors. We are very reluctant in going to alternative donors sometimes with these patients with huge spleens, especially cord blood. There is a very, may or may not be right, but there is always this fear of engraftment failure because the marrow is so fibrotic and the spleen may suck up all these cells and delay engraftment and so on. So the experience with alternative donors is more limited in these diseases. As in CML, I think treatment-related mortality has to be reduced for this to make sense. Otherwise, the balance risk-benefit doesn't go. With that, I'll finish. Again, acknowledging my colleagues, and this is Dr. Champlin, who's here, Dr. Popat, who runs this myelofibrosis program, and I'll stop here. Thank you very much.